name is Chris Ornelas. I'm one of the physiatrists who is working at the USC Spine Center. I'm joined today by Betsy Schaefer, who's our administrative chairperson, also by Dr. David Cheng and Dr. Gene Tekmyster, who are both interventional physiatrists like myself. We're very proud of the fact that we've been able to offer so much educational opportunity in the LA area over the last 5 years. We've hosted a number of spine conferences and symposium. We're scheduled next year for our first international spine conference that is hosted by the USC Spine Center. And we are now just starting with today's very first preview of a telecommunication type education series that we're going to be able to roll out for the upcoming year. And so I'm just going to go through my slides here, which will be a very brief introduction, and then I'm going to turn it over to our speakers for the night. So the goal of the USC Spine Center is to be recognized as worldwide as a leading academic spine center for appropriate, state-of-the-art, multidisciplinary patient care, spine education for the next generation spine surgeon, interventional physiatrist, and innovative spine research. And so what do we mean by that? Our providers are associated with numerous organizations, but not just locally, but abroad. We've hosted and coordinated with multiple organizations over the world, collaborating and working on spine conferences in every continent. And Dr. Jeff Wong, one of our co-directors, was the previous president of AO Spine International and recently of North American Spine Society. So we hold leadership positions in many of the larger organizations regarding spine. We want to be recognized as providing appropriate spine care. And so as cartoon I like to show is you called me just in time, another day or two, and you would have been up and around. And it's important to understand that people with low back pain and people with neck pain, a lot of times they get better. So it's important to evaluate these folks, and it's important to be available to treat them. But it's not necessarily that if you have a hammer, everything is a nail. So just because we have the ability to do some of the treatment options that you can hear about today doesn't mean that we always have to. State of the art, we have 3 O-arms within our 2 major hospitals. We use stealth technology, MIS approaches for surgery. We're reintroducing endoscopic spine surgery. We have biplanar fluoro and multi-fluoro options for our interventional-based procedures if we need to. And so we really have a tremendous amount of resource in order to treat patients and provide care. Multidisciplinary patient care. We have a group of 9 providers now at the Spine Center. We have 3 interventional physiatrists, all of us which are speaking today. We have 3 neurosurgeons, Dr. John Liu, Patrick Shea, and Thomas Chen. And we also have 3 orthopedic spine surgeons, Dr. Jeffrey Wong, Mark Spoonemore, and Raymond Ha. We provide a lot of education. We have a fellowship program for spine surgery. We take both neurosurgery and orthopedic spine surgery. Per year, one that rotates through part of their neurosurgery residency, and 2 others that are invited to our program through the match. We have a spine medicine fellowship, and we're finishing up our 2nd year. We'll be hosting our 3rd fellow in a few months. We host a series of international surgeons and PhD researchers, and we collaborate with people all over the world on continuing education and research. We work with our School of Engineering, with the Eli Center for Regenerative Medicine, our Norris Cancer Hospital and Center. We work on tissue engineering and regeneration. We're going to hear a little bit about some techniques by Dr. Tekmyster later today. And we have a lot of data going on at any given time with all our providers on clinical outcomes and research. We do more functional MRI research than any other program in the country. We have multiple locations. We have our large hospital, which is the Keck University Hospital in East downtown area. We have the Verdugo Hills Hospital, and we do primary elective surgeries in these 2 locations. We have multiple clinics. We have the Toyota Sports Performance Center. We have a clinic in Beverly Hills. We have offices in Pasadena. We have offices in La Cañada, Flint Ridge, and Verdugo Hills. And the reality is with telemedicine, we're actually everywhere now. Multiple providers are offering telemedicine visits for not only new evaluation, but for follow-up. And this really gives us the ability to improve our access. It used to be that I spent 1 day in one clinic and 1 day in another part of the LA. But now if I need to follow up with a patient or even see somebody, it really doesn't matter where they live or where I am. We're able to provide telemedicine visits and give care to folks. And all our providers, all 9 of us, are implementing telemedicine and inpatient visit as a hybrid model. This is our group. These are some pictures from our last year's conference and the year prior. We're very excited about a conference we were going to have upcoming this year, but due to the COVID-19 virus, we were able to reschedule that till next year. And so we're real excited that we're still going to be able to move forward with our international conference, and so there'll be more details on that to come. With that, I'm going to go ahead and turn it over to Betsy, and she can introduce our next speakers.
Okay. Sorry, Dr. Ornelas, your audio is cutting in and out, so hopefully for Dr. Cheng, his will go smoother. Can you stop sharing, Dr. Ornelas? Okay, and Dr. David Cheng is going to speak next.
Hello, everybody. This is my first time using Zoom. Can you see the screen okay?
Yes, we can see it.
Perfect. And can you hear me okay?
Yes, we can hear you okay.
Okay, terrific. Well, thanks you so much for having me. I just want to first hope that everybody is safe during this COVID crisis. As Chris mentioned, my name is David Cheng, and I'm new to the USC system. I've been in practice for about 8 years or so. I'm a fellowship-trained physiatrist. I've been in practice previously at Rush in Chicago, and wanted to welcome all my former residents that are on the call today. I'd like to take the next 20 minutes and talk about a new treatment, intraosseous basivertebral nerve ablation. And the way that I like to organize this talk is, for the first half, describe the history as well as the development of the procedure. And the second half of the talk will be talking about the techniques, the outcomes, and future directions. And I have no financial conflicts of interest. I'm a member of AAPMR, North American Spine Society, and Spine Intervention Society. And I serve on a few research and education committees in these organizations. So we know of low back pain as generally benign, and I'm just going to jump right in. And I suspect most of the providers on the call probably have treat low back pain often. I put the word benign in quotes because although most patients recover within 3 months, the rate of recurrence is very high, and that number rises to about 2/3 within a 12-month period. And even for those that improve, when the symptoms recur, they're at a higher risk for developing chronic symptoms or refractory to treatment. We know that in the US as well as worldwide, it is one of the most common causes for patients to seek care, and it's one of the most common causes for disability. So to call it a benign entity is a misnomer. There are many available low back pain treatments, and we'll just go from left to right, from the most conservative to the most. Exercise, medication, complementary or alternative medicine. For the purpose of today's talk, we're going to focus our attention on injection and, of course, surgery. Unfortunately, outside of diagnoses such as radiculopathy, spinal stenosis, spinal listhesis with instability, the diagnosis is non-specific, and the treatments can be very confusing. The same problem also applies for injection options for low back pain. Low back pain is a symptom and not a diagnosis, and so oftentimes we provide injection therapies to patients in a less than organized or thought out fashion. When we introduce prolotherapy because increased irritation, when that doesn't work, we consider story injections to decrease inflammation. We can heat the pain with thermal ablation. We can freeze it. If the lesion is too small, we want to get a bigger area. We can put cement in it if there is a vertebral fracture. And if that doesn't work, we can stimulate it or we can regenerate it. And even though we have a whole host of injection options, patients are often very bewildered, and we end up practicing what I call a la carte medicine, where the onus is really placed on the patient to make treatment decisions. This is a common struggle, and it was a struggle when I was in Chicago, and it's a struggle today. I imagine many of you are experiencing the same things. And so the reasons for that are also well known. The low back pain, a large percentage of that is considered non-specific. And with non-specific low back pain, non-specific diagnosis, there is also no specific treatment. So it's really no surprise that the outcomes are underwhelming. Historically, however, the intervertebral disc has been carrying the weight or the blame for a lot of these axial flexion-based chronic low back pain. And hence the discogenic low back pain model was born. The concepts, I'm sure, are familiar to all of you, is that begins with first either a fissure or a tear of the annulus. The annulus does not heal. There's poor vascular supply to the disc, and so the nociceptors.
Okay, you got it. Remind Dr. Lee for tomorrow.
Sorry about that.
That's okay. Become hypersensitive. So even now in 2020, the diagnosis of discogenic low back pain is controversial. I have a picture on the right side. This is a clinical guideline and manuscript. So things we think of are discography, and provocative discography is most commonly described. That, of course, involves injecting, contrast, pressurizing the disc, and interventionalists are looking for concordant low back pain, and this is used in conjunction with the procedure done at asymptomatic levels for control. Second, there are MRI findings such as Furman grades, looking for disc degeneration or degradation, and Modic Type changes, which we're going to talk about in great detail. And the last standard is surgical outcomes. Okay, but between the three, there is still no true gold standard. Let's talk about MRI findings in chronic low back pain. So I want to discuss Modic Type end plate changes. These, of course, are signal intensity changes that happen in the vertebral body, along the bone marrow, especially adjacent to a degenerative disc. The prevalence of these findings can go up to as high as around 60% in patients with degenerative disc disease. And I am providing you guys with pictures of type 1 and type 2. So here you're seeing T1 weighted image on the left side and T2 weighted on the right. So it is dark on T1 and bright on T2. This signals a more acute process, and the clinical takeaway is that there is bone marrow inflammation and edema. In Modic Type 2 changes, brightness or hyperintensity is seen on both T1 and T2. This is more of a subacute process, and you're seeing that there's a conversion of normal red hemopoietic bone marrow to now yellow fatty marrow. And this is indicative of bone marrow ischemia. So we know that patients with these type of changes on MRI, particularly type 1 and type 2, don't do well. And in that, I mean that they seek care more often. When they hurt, the pain lasts longer, and they have worse outcomes with those conservative treatments, and also curiously with surgery. But the question here is, why do they do worse? And so from a non-surgeon, I have a few thoughts. Usually when a treatment doesn't work, I think about, well, is the treatment a poor treatment choice for the diagnosis, or is it number two that there are competing pain generators, or that we have the wrong pain generator or the wrong diagnosis from the get-go? In other words, is surgery a poor treatment for discogenic low back pain, or are positive findings on MRI and positive findings on provocative discography non-specific for discogenic low back pain? We know that even back in the 1990s, Hagness showed that injection through provocative discography, it's meant to pressurize the disc, but this often also causes the end plates above and below that disc to deform. So perhaps patients do poorly with surgery because the pain was really not discogenic, but actually from something else. So this leads us to the next slide and my introduction for the procedure. Here we're making the case that perhaps the pain is not coming from the disc, but rather from the vertebral body. I have a few research studies to share with you. The first is a clinical study, and this demonstrates that patients that underwent spine surgery, this is back in the 1990s, under local anesthesia, that mechanical end plate stimulation during the surgery actually caused significant pain. And histologically, there are also things that point us to the vertebral body and the end plates as a possible pain source, and that is patients with chronic low back pain. There's increased blood vessel proliferation, the damaged end plates, the density for the nerve that senses end plate pain, the basivertebral nerve, that density is much higher. And we know with the immunologic staining that that nerve stains positive for substance P and for protein gene product 9.5. Both of those items, both of those proteins are implicated in pain transmission. So here, I'd like to propose a new treatment for chronic low back pain that for patients with vertebrogenic low back pain, we use the basivertebral nerve as a possible target to intervene with the pain transmission. So this procedure and this company described the technique back in 2011, but the actual procedure was made commercially available in July of 2018. There's only one company in existence right now, and that's Relievant, that produces equipment for this procedure, and they call this procedure, the trade name is Intracept. So again, FDA approved in 2016, commercially available since July 2018. The target area, I want to first turn your attention to the diagram on the right side. And you can see that picture on the right in green is the basivertebral nerve. You can see that that nerve enters the vertebral body posteriorly, and it goes through the basivertebral foramen, that's marked in purple, located at the midline of the posterior cortex. This nerve courses anteriorly to about 1/3 of the vertebral body before bifurcating and splitting to the superior and inferior end plates. So the target, therefore, is before the nerve splits up. The fancy word that comes up again and again is arborizes. I think that's a really descriptive word. So we really want to target the nerve before it splits up. These are the indications for selection criteria for the procedure. They also apply for available research studies, and they are that including patients who are skeletally mature, so adults that have failed 6 months of conservative care, patients with moderate disability and moderate pain. Here, disability is measured by Oswestry Disability Index of greater than 30 points. This technique is FDA approved for changes at or below L3. Okay, so from L3 to S1 Modic Changes, type 1 and type 2. I'm going to talk through each steps. We're going to make it very simple. So step 1, the procedure is done under fluoroscopy with moderate sedation for general anesthesia. It begins with accessing the pedicle with the introducer that you see here. For the interventional pain specialist on the call, this is similar to a kyphoplasty technique. The second step, a channel is created and a curved cannula is used for this purpose. After that, a radiofrequency probe is placed into that channel. This is fluoroscopic view, AP view, to make sure that the probe and the leads are exactly midline, so that we can use bipolar radiofrequency and create a 1 centimeter spherical lesion. So the third step, as I said, you can see that the probe is placed proximal to the terminus of the basivertebral nerve. There is a 10 millimeter cushion that is kept just anterior to the posterior wall. And the purpose of that is to protect, obviously, all the neurostructures within the spinal canal. You can see that the bipolar radiofrequency forms a circular lesion, a spherical lesion, I should say, and the probe is heated to 85 degrees Celsius and held there for 15 minutes. So for every level that's treated, we do the end plate above and end plate below. Okay. Next, I'd like to review with you the landmark studies for this procedure. So there are 2 studies that you'll see again, and so that's the INTERCEPT study and the SMART study. Both of the studies are level 1 randomized controlled trials and published in 2019. The first INTERCEPT study demonstrates efficacy, and the second study, which I'm going to talk about, is the SMART study, and that demonstrates the duration effect at 24 months. I have about 5 minutes left, so I'm going to go through the methods, kind of my thoughts on the strength and the conclusions that we can reasonably draw from the research study and clinical applications and future steps for us at USC Spine Center. So the study design is prospective, double-blind. Patients are randomized to the treatment arm or the sham arm. Here, it's important to know that for a sham, for the very first step, the dock introducer is used, and it's placed 1 to 2 millimeters into the pedicle. I didn't get that. And radiofrequency ablation is then simulated with the equivalent time of 15 minutes. Patients are followed for 24 months. Here, you see that the functional improvement really is captured almost immediately at the 3-month mark. For the efficacy study, you see that at the 2-week mark, there is a drop and it stays there, and it actually trends even better at the 2-year mark. So out of 100 points, you see 42.4, which technically falls under the lower category of severe disability to 18.8, and that is moderate disability. So there's a total drop of more than 20. The term that we use in pain medicine is minimal clinically important difference. In here for function, it's 10 points. So you can see that here, through the SMART study, that the drop, the improvement in ADLs, disability, and ODI is 23.6 points, which is drastically greater than the 10 points required. So these findings are present at 3 months and sustained at 2 years. Next, we talk about pain. And pain, again, we're seeing similar improvements that are sustained at the 2-year mark. Equally important are other markers for improvement, and that's what I mean by that is patients in the treatment arm require significantly less opioids and also decreased number of spinal injections at 1 and 2 years respectively. Lastly, there were no serious complications, no procedure or device-related problems like broken devices, pedicle fractures, vascular necrosis for accelerated degenerative disease, no spinal cord or nerve problems, and no infections. The most common complaints were transient incisional pain and urinary retention. Since this is a CME talk, there are some methodological concerns that I have. that may impact the way that we perceive the value of this study. First, since Relievant is the only company, all the studies that I mentioned were industry sponsored. Secondly, the population that were included abided by some very strict patient selection. I included a slide with selection criteria, but what I did not mention were the multiple exclusion criteria. Not surprisingly, they include radicular pain, symptomatic spinal stenosis, disc herniation, opioid dependence, and obesity. So the practical real-life question is whether loosening the criteria for this procedure would affect the outcome. Next is the comparison or sham arm. So even though it's very thoughtful for the authors to use this introducer and docking it just at the pedicle, the question that I have is whether the patients that are undergoing this therapy truly feel like they got sham or they were totally clueless. Obviously, the more invasive the procedure, the stronger the placebo effect. These patients are adult patients, right? There's no underlying osteoporosis or osteopenia, so I imagine that the procedure, at least the procedure would feel different with sham versus the treatment arm. And so the patients going in who are assigned to the sham therapy suspected that they are more likely to be in the sham category, then perhaps that may impact their perception of pain and therefore their outcome at 3 months and 2 years. Lastly, the VAS scores compared to improvements in function were less impressive. And so even though it meets MCID, it is just over that kind of lower threshold. Clearly for something like chronic axial low back pain, our expectation for something that is so intractable and difficult to treat is lower. But it's something to keep in mind that even though it's statistically significant, the difference is not quite so drastic. This is my last slide, and in summary, I believe that the basivertebral nerve radiofrequency ablation, it's been out for 10 years or so, but it shows this early promising evidence. There is research that will be published sometime this year for 5-year data, and it shows us that the procedure is safe. There's a 75% satisfaction rate. 80% of patients in the INTRACEPT study would repeat the procedure. There is statistically significant improvements in VAS, and that is about a 2.5 centimeter improvement. But more important than that are the very impressive improvements in function and also practical improvements in reduction of opioid consumption and resource utilization. These effects, as shown by the studies that I demonstrated, were present and sustained at 2 years. But we know, having corresponded with Ray Baker, who's this CMO for the company, that those results actually continue until the 5-year mark. The hypothesis, the reason that the procedure confers this type of duration of effect is that the nerve is largely unmyelinated. So for these patients, once the nerve is ablated, that none of the patients in the study needed a repeat procedure. So I am going to end my talk here. I know that Gene has one coming for you. I believe that we're going to reserve all the questions at the very end. On the USC side, this procedure went through our value analysis committee, so we're looking to offer this treatment in the coming months. I thank you for your attention, and I'll turn it over to Gene.
Thanks, David.
While Dr. Tekmyster is getting his slide ready, I just want to say that if you have any questions for Dr. Cheng, I received a few during his talk. I went ahead and emailed them to him so you could prepare for them. But if you have any further questions, just send a private message over to Dr. Cheng, and he'll try to answer the top 3 or 4 questions we have, and then we'll kind of go from there.
Thanks, Chris. Thanks, David. Thanks for USC Spine for setting up the conference here today. We're all looking forward to going to Hawaii, but I think in light of circumstances, we'll wait a year and plan it and go from there. My name is Gene Tekmyster. I'm a physiatrist at Keck Medicine, USC, specializing in interventional spine care and regenerative and sports medicine. I practice primarily out of the Toyota Sports Performance Center, which is located in El Segundo. I also spend time at the Spine Center on the Keck campus. So I'll be talking on regenerative treatments for spine conditions, pretty much taking up from where Dave left off, talking about axial low back pain, discogenic back pain, what is some treatment options before they progress to what the intraosseous nerve ablation does, which is treat vertebrogenic pain. That is a more chronic condition where the disc and the end plate, which is a single organ, demonstrate continued deterioration. Disclosure is non-relevant to this talk. I do have some speaker and advisory appointments, as well as sit on some committees on national organizations. Some of the things we are going to be talking about today, which includes platelet-rich plasma and stem cells, are considered off-label use or not FDA approved or evaluated. So that just be mindful of that. We'll talk about some regulatory affairs, some basic science overview, discuss platelet-rich plasma, talk about stem cells, look at some case examples recently, and give you an idea of what is out there, what one should expect, and maybe allow you to answer some questions for your patients or present them for treatment. As David had mentioned, low back pain is the leading cause of disability worldwide, and is and should be a priority for treatment, not only for prevention, but also treatment once it does occur. So what is the goals of regenerative treatment? What are we trying to really accomplish? Can we speed up the process? Can we cheat the process in some way to allow for tissue healing? The goal of regenerative medicine is to facilitate this healing, but can we actually do this in an in vivo with exogenous compounds? Can we even show or slow the degeneration or stop the degenerative process, as we have seen with some of the end-stage MRI images that David had shown? The main target is going to be the intervertebral disc. We do have a pretty good palliative treatment for facet or Z-joint mediated pain being radiofrequency ablation with a dual diagnostic radial branch block. Radiofrequency has been shown to be very effective. Can we reverse some degeneration in arthritis within the facet joint? Maybe, maybe not, but most of the research has been done on studying the intervertebral disc, and as such, I'm going to focus on that topic. What is allowed by the FDA? And this is talking about clinical practice, and I'm not talking about an IRB approved clinical trial. As of recently, and if anybody's heard the podcast Bad Batch and other stem cell issues that have occurred with contamination, the FDA released some guidelines. We are allowed to use autologous stem cell harvested from the patient for homologous use, adding autologous broad products. We're allowed to do platelet-rich plasma, fibrin, which is platelet-poor plasma. We're allowed to centrifugate and allograft marrow cells that are contained in bone. We cannot culture cells. We cannot take cells out of that single procedure room where we are harvesting them and ideally injecting them back to the patient. We can sort, we can add growth factors. There's no enzymatic cleavage. We can use mechanical separation, such as centrifugation, but not enzymes. And recently, amniotic fluid. Because it is not an autologous product, we're not allowed to use it. And so if you have a rep coming in that says, hey, we have this amniotic cord, stem cells, the answer, unfortunately, will be no. In order for something not to be considered a regulated drug, it must meet the following criteria. It has to be autologous, minimally manipulated, homologous use for the same surgical procedure, which means you can't harvest it, bring a patient back and re-inject it, and it can't be combined with any other product. So a little bit of overview. Stem cells, we've already heard them. There's a broad variety of different subclasses and categories. I'm not going to go into the basic science too much. It's a general overview so you have an understanding or comprehension of what we can and can't do. Bone marrow can be taken from aspirate or concentrated via centrifugation. Fat can also be mechanically separated, but not enzymatically. Some evidence that PRP does have a benefit in disc annular tears, and we'll go through that a little bit more. There's also some recent evidence that it does work in hip and EOA pretty well, as well as other tendinous and ligamentous injuries that I'm sure you've heard of. Amniotic tissue, however, most of the growth factors are not alive and we can't use it anyway. So let's talk about PRP. Platelets represent a small substitute or a small constituent of whole blood, where the usual concentration is about 150 to 450,000 per microliter of blood. Ideally, if you want to have a product that is going to initiate a healing or a regenerative response, you want to make about 5 to 6 times the concentration. So if you have a patient with a 200,000 platelet count, you really want to get to that 1,000,000 platelets per microliter. And there's some evidence to show that that's the magic number. Some kids do not concentrate as well as others. So ideally, you want to vent it for appropriate concentration of platelets. We're not testing every single person that undergoes PRP to make sure that the concentration is adequate. But if there's a track record of a certain kit or a certain manufacturer that makes a product that it does concentrate it to that record, then that would be ideal. Anything that's less than 1,000,000 is probably inadequate, and I would not consider it platelet-rich plasma, but just autologous blood. The most mechanism, we're still not 100% sure, but the question remains, is the pain relief on its own constitute enough of an indication to promote the use of PRP? PRP initiates the body's own repair process and modulates inflammation. It also delivers growth factors and promotes a healing environment. But it does have an anti-inflammatory effect as well as an analgesic effect. So if it attenuates hyperalgesia and it reduces pain, is it necessary to show that there is regeneration of healed tissue? Just some questions to think about while we continue adoption of PRP in our clinical spine practices going forward in the years to come. Are we trying to achieve pain relief to improve function? Or are we really trying to regenerate tissues and promote healing and regeneration? Can we do both? I think a lot of those answers are still yet to be determined. There have been many in vivo studies that reported similar results with those found in vitro. Restorative effects in musculoskeletal degeneration, downregulation of pro-inflammatory cytokines, consistent and well-defined in vitro results. The in vivo, a little bit more variable, but still consistent on an improvement scale. And again, I bring up the point, is it healing or is it pain relief that we're after when we're looking at the clinical effects of PRP? There's only one double-blind randomized control study for PRP for the lumbar spine as far as axial, low back pain, and discogenic pain. There are some prospective studies, but again, only one true double-blind randomized controlled trial, and I'll talk about it a little bit later. In 2016 and 2017, a few papers were published as far as looking at platelet-rich plasma injection for chronic discogenic low back pain, showed somewhere between 47 and 57% improvement, which is just about where the basivertebral ablations are, and is that clinically significant? If you have a patient with chronic low back pain with an axial component, with a discogenic injury, functionally limiting, is 50 to 60% enough of an improvement to pursue this type of treatment. Intradiscal PRP injections do show continued safety and improvements in pain and function even at 2 years, if you look at the MONFET study in 2016. So we do know that they do seem to work. They're relatively safe, minimal adverse events. So now we need to see where that improvement is coming from. As I alluded to earlier, is it a regenerative issue? Is it a pain relieving issue? In 2019, the American Society of Interventional Pain Physicians released biologic guidelines. PRP and stem cells have been referred to as interventional biologics, interventional orthopedics, regenerative medicine. So all of those are synonyms at this point. And there is fair evidence for a use of PRP in intradiscal injections for axial low back pain in discogenic in origin. Another review in 2019 also showed that PRP was safe, it was effective in reducing low back pain. As we see, PRP has a consistent analgesic effect in the clinical setting. Is the effect greater than other things that we have at our disposal? And again, this is a rhetorical question because we don't really have a good treatment for discogenic low back pain. What Dr. Cheng was alluded to earlier is basal vertebral nerve ablation works on more chronic discogenic pain or vertebrogenic pain when you already start seeing end plate changes. In some of the MRI images that I'm going to show you later, the bone marrow hasn't changed at all. So it's a purely discogenic in origin pain etiology. So what other options do we have? Do we do a discogram? Do we surgerize? Do we continue with conservative measures that most likely these patients have failed if they have this chronic back pain for 3 to 6 months that is quote unquote not really benign at this point in time? And again, I point to this recent review that the evidence of tissue repair is somewhat lacking. As far as the randomized control study that was done in 2016 showed a treatment satisfaction of 56% to placebo at 18%. It was a prospective, double-blind, randomized control study with an N of 47, with intradiscal injections showing improvement at 8-week follow-up. And the findings were statistically significant in those who received intradiscal injections in regards to those that did not. So what do we do now that we have this information? The preclinical data in animals model is great. The clinical trials are modest but encouraging, and the potential is certainly there. I firmly believe PRP or some version of a blood product will be developed to heal injured tissues. In the right patient at the right time, this may be a treatment that can be considered. Again, I think patient selection, technique, appropriateness of use, and kit selection is most vital in making sure that the patient improves and continues to do well going forward into the future. Let's talk about a little bit of bone marrow aspirate. When we talk about stem cells, that's what we usually think about. Typically harvested from the iliac crest. It is a painful procedure. Multiple aspirations are really needed in order to obtain a significant enough volume for it to be processed, concentrated, and injected back into the patient. It does contain some free progenitor cells, but the hope is that the combination of the stem cell from the bone marrow as well as some blood product together can activate each other in order to promote healing. You could also theoretically obtain stem cells from fat aspirate, adipose-derived stem cells, usually in the infrapatellar or the periumbilical fat harvest, essentially liposuction. You can shake, vibrate, ultrasound, or more commonly centrifugate them in order to process them, concentrate them, in order to be delivered via an injection route. It does have a somewhat potential higher count of mesenchymal stem cells, but that yet is questionable. So let's move on to what we're trying to achieve, and that's to harvest these mesenchymal stem cells. They're a pluripotent endogenous population that are capable of differentiation. Are we sure that they're going to make a cartilage that is very much like the annulus of the disc? I don't know, but they do have the capability. They stimulate tissue recovery with modulation of a local inflammatory response, can be immunosuppressive, and very limited results showing uncultured stem cells. There is some benefit, but may not be directly from regeneration. It may be more of a signaling effect as far as regenerating or facilitating the body's own natural healing process. As far as the clinical trials, we're going to be talking about a couple different ways. We're going to start off talking about autologous stem cells, and then we'll talk about some culture products, which obviously need IRB approval. One recent prospective study, percutaneous injection of autologous bone marrow concentrate, which can significantly reduce lumbar discogenic pain, with the results of 61% of patients had a greater than 50% decrease in their visual analog scale. So that 60% had greater than 50. Is that enough for us to consider that this is a treatment modality that needs to be further investigated? Yes. Is it enough to offer this to everybody? I would say at this time, probably not. I think additional resources should be aimed at making sure that this is, in fact, a treatment that we can facilitate injury recovery. When you look at this study, they did additional 2 or 3 year outcome trials, treatment of discogenic pain with autologous bone marrow, as well as a 3-year follow-up with, again, the results being somewhat diluted. You have 60% of patients getting better 50% of the time. That's not to say everybody got 50% better, only about 2/3 did achieve clinical improvement. Some of the cultured stem cell trials, and these are again IRB approved clinical trials, and you can't use the cultured stem cells in clinical practice, but there may be some improvement that is noted. Again, modest but not huge success, 50% improvement, 6 and 12-month success, maybe up to 70% in certain trials. So again, tread cautiously when talking stem cells with patients. It's being touted as the cure-all, but for spine, I don't think we're there yet. I think a lot more research needs to be done. And stem cell summary, non-cultured bone-derived mesenchymal stem cells lack preclinical and clinical data. Regulatory restrictions prevent cultured treatments, and we certainly need quite a bit more both preclinical and clinical data in addition to optimizing growth factors, trying to figure out where exactly the mechanism of improvement here is. Is it the stem cell? Is it the blood product? We looked at evidence for PRP that shows that there's some regenerative effect, analgesic effect, anti-inflammatory effect. Are we doing any regenerative medicine at all? Are we using purely analgesic effects of these injectable therapies? So to go back to the beginning and to tie this back, axial low back pain and discogenic back pain, which is a subset of that, is a severe condition affecting quality of life. The evidence is weak, but there is some potential effectiveness. I don't think it's main time yet, but we do see a potential in these treatments. Appropriate stealth technique, precautions, patient selection are paramount when choosing regenerative therapy. And above all, I think we need to focus on things that will make people better. And at this time, we don't really have many options for discogenic low back pain. What I want to do really quickly is take you through a few recent cases to highlight the importance of patient selection and being judicious in presenting the treatment options to patients. Just because the treatment's available does not mean everybody's a candidate. Having very strict and narrow criteria is vital to ensuring optimal outcomes, especially when the treatment that's still considered experimental and investigational. Just because you can doesn't really mean you should. I won't go into details in identifying each case. You can see a quick run through here and a synopsis of all the treatment options, but these patients have failed significant trial of conservative treatment, even other interventional procedures, including epidural injections, facet blocks, medial branch blocks, and the such. But I want to kind of quickly get you through some of those examples. Before we go on, I know David alluded to this earlier, but this is a discogram reference, and I want to point out, especially the ruptured and the fissured pattern, which is number 4 and number 5, as you can see below, because I will be showing some discogram images to show you the structure of the disc when all others are normal. So this is our first case, 26-year-old female. As you can see on the MRI, the L4-5 level, there's a small disc protrusion, an abnormal L4-5 disc desiccation as compared to the other normal levels. Failure of all conservative treatment, PRP was given as an option, and the patient decided to proceed. You can see the needle in the epicenter and the geometric center of the disc, and then you can see the discogram pattern. And again, you see a ruptured classic pattern with extravasation of contrast posteriorly into the epidural space, allowing the with an annular fissure, which allows the injected fluid to escape. In follow-up visit, and this person did have PRP, obviously, and reported continued improvement of symptoms. 8 months status post-procedure, she presented with a new complaint of knee pain with a history of 80% improvement of her axial low back pain symptoms, with, at the same time, functional gains would return to pre-morbid levels of function. Case 2, again, a younger patient. This was a Division I field hockey player. This was her senior year. She was having significant amount of axial low back pain. If anybody else seen field hockey, there's a significant moment of flexion, especially when they run. If anybody has seen discogenic pressure studies, that standing flex posture increases the axial load in the lower lumbar spine. Again, you see an abnormal L4-5 disc with the rest being normal. So we have a definitive target, ideally, based on her history and her evaluation. Again, here's a quick image of a discogram, and you can see the extravasized contrast posteriorly. It's an atypical, but a ruptured radial tear is noted. What I'm going to show you next is once you inject the contrast, you can inject the PRP, excuse me, you see the PRP is taking up the posterior portion of the injected. The contrast is staying in the anterior nucleus, but is filling up the gap and is pushing the contrast out, staying in the posterior of the disc. 8 weeks post-procedure, she reported significant improvement in pain, was able to participate and swim across the Sound, which is a 25-kilometer swim relay in the non-wetsuit division. It's a 5-person team, and it's a fundraiser that's held in Connecticut, which is where I was practicing when this case was performed. Our third case is a little bit older gentleman, 44-year-old male. Again, normal other discs other than the one that we're aiming to treat. This is at the L5-S1 level. You can see both the sagittal and axial view here. Here's the discogram pattern. Again, is seen as the top 5 ruptured type with the final stage of disc degeneration. And I'd like to point out that there is no vertebrogenic changes. There is no Modic changes in the gentleman. It's purely a discogenic process here without having extension into the vertebral body. So before they get to the chronic process for which maybe the basovertebral nerve ablation is an option, maybe this can be a stopgap measure to try and prevent some of the degeneration from advancing further. This patient presented 1 year later with new complaints of shoulder pain. He was a painter, so a lot of overhead activities, had no back pain, had some stiffness, but was not limiting and was able to return to normal physical activity. No longer taking any analgesic medications, including Lyrica and Tramadol, which he was on prior to the PRP treatment. Case number 4 is a nursing student. She was involved in a motor vehicle accident. Again, you see one dark disc showing disc desiccation and injury to the disc, 3 normal levels. And I do want to say that just because you see this in MRI, that does not mean the patient's symptomatic. But when they are symptomatic and you get concordant imaging, that may be something of relevance. Just because you see it on the MRI doesn't mean it's causing pain. The classic study, which was done in 1985, shows about 60% of patients over the age of 30 have abnormal findings in MRI without pain. So everything has to be in concordance: the pain, the treatment, the options. Here again, we see a type 5 rupture pattern on the discogram scale with the contrast embedding posteriorly into the annulus. 1 month post-procedure, she did report a decrease in low back pain. And 3 months post-procedure, she was able to return to her clinical nursing rotations with minimal symptoms and again, an 80% improvement in pain. The last case that I'll quickly share with you, and we'll get to some questions here, is a 30-year-old gentleman with axial low back pain. Again, this is a workers' comp injury. He was injured in, I believe, January. The PRP was done in September. He went back to work full duty in February of the following year after the PRP was performed in August. Had a re-injury, but was able to do full duty activities for approximately 6 months before a second injury. And again, you see a type 4 fissure pattern where the contrast is leading to the outer ledge of the annulus. And then we repeated the MRI. This is prior injury to the injury. So not a lot of change. So did we halt the degeneration anyway? I think it's a little bit hard to tell, but there's definitely some analgesic effect to the PRP. And then again, after the second PRP, he started to go back to work on limited hours and duties. So above all, I just want you to think about being ethical. Consider the research when it comes to stem cells. I do not think it's a panacea. Are we going to get there? Maybe, but I think more studies are certainly warranted. And don't forget to do your core exercises, focusing on both the anterior and the posterior midline. Sit-ups are great, but they shouldn't be the only way to do it. Weighted sit-ups can certainly help. So thank you for your time, and I'll hand it back to Chris, and we'll do some Q&A.
Okay, great. Thank you both for your time, for offering the questions. Dr. Cheng, I sent you a few questions, and I think you may have reviewed a few in the interim. Can you take a look at those and maybe read out the top 3 questions that you got, and then go ahead and answer them?
All right, I'm happy to. I have some questions for Gene also. The first question is, how does intracept procedure ablate a neural pathway that is not ablated with radiofrequency rhizotomy? Well, I think the diagnosis, the pain generator that we're trying to address are different with the radiofrequency rhizotomy or facet radiofrequency ablation. We are looking for patients with extension-based pain, someone that has facet arthrosis or facet-mediated pain. Intracept procedure is used for pain in the vertebral end plates. And so with objective findings, of Modic type 1 or type 2 changes. So one thing that I wanted to mention and echo what Gene said was that we all know that chronic low back pain is difficult to treat, and I don't think either of us, Gene or myself, are presenting these treatment options as the cure for all patients. We believe that this can fit a subset of patients. For the intraosseous procedure, I wanted to say that this is actually covered by insurance, and we estimate around 1/5 to 1/6 of patients with chronic low back pain as having possibly vertebrogenic low back pain. The second question is, do you use local or sedation? Well, since this procedure involves introducing the trocar into the vertebral body, I think local anesthesia is insufficient. I would use, at the very least, moderate sedation or general anesthesia. And the last question is, why is urinary retention a common side effect? My suspicion is that this is not so much a side effect of the procedure, rather it is a side effect of the medications used during sedation.
Excellent. Dr. Tekmyster, do you have some questions to review now?
Absolutely. So the first question is, any thoughts on the disc mygrome and dysbiosis? Absolutely. This has actually been a really fascinating to watch over the last several years. We still don't know if it's a subclinical infection that causes disc degeneration. There was a study several years ago out of, I believe, Korea that showed that it is some microbacterial change that causes disc degeneration. And I know there was a recently study released just a couple of days or weeks ago that I haven't had a chance to read yet. But I think that there is something to be said about the microbiome. When I do the PRP procedures, I usually do IV antibiotics and draw the PRP 20 to 30 minutes after the antibiotic is initiated. So my hope is that if it is a subclinical infection that causes or facilitate disc degeneration, there may be some microscopic antibiotic molecules in the injectate when they do the PRP. So it's actually something that I really thought about. So great question. And the other question is, what is the difference in efficacy, if known, between fat and marrow-derived stem cells? I don't think there is any. I think ease of collection of fat is something that people are sort of drawn to. Bone marrow has both blood products, so I think the efficacy is still yet unknown. And above all, we don't know the efficacy of stem cells overall, so it's really hard to compare both bone marrow-derived and fat-derived stem cells. We don't know the efficacy of each, so doing a comparison I don't think is necessary or even needed at this time. I think we need to show that stem cells actually do something before we start to use it regularly.
Well, I want to thank both our speakers for their time tonight, and I want to thank everybody for joining in. You know, we had people from many different backgrounds. We had therapists, we had physicians, we had surgeons, we had people locally and people as far south as Brazil actually on the call today. So we're really excited that everybody was able to participate. I'm going to turn it over to Ms. Schaefer, who will give you some information on how you, and actually in Nagalian, there's a message that's going out to everybody if you just look in the chat. And you can get information on how you collect your CME for our event.
Thank you, Dr. Ornelas. So Lena, Gallian, and I have been messaging everyone to make sure that we get your information. We'll need your first name, last name, your medical credentials, as well as your email address so that we can issue you your CME certificate. I'll stay on for a little bit. That way you can message me in the chat. I've also provided my email address in the chat. That way if you need to reach me after the webinar, then you can just go ahead and reach out to me via email. I think that's everything. Dr. Ornelas, did you want to go ahead and end it?
Yes, like you said, you'll stay on here for just a little bit, but the event has come to its conclusion. So thank you all so much for participating.
Thanks, everybody.
Thank you all for having us. Good to see everybody. Bye-bye.
Bye.